Good afternoon, dear colleagues and dear guests. I appreciate your time in the following minutes for presenting my paperwork. My name is Horatiu Vultur. I am head of Rare Blood Disease, Haemophilia, and Light Disorders Department in Giurgiu District Emergency Hospital in Romania. My subject for today will be the importance of musculoskeletal ultrasonography in patients with hemophilia. Even though this is a rare blood disease, the impact still remains on joints and muscles depending on the place of injury. Hemophilia is described as a congenital X-linked coagulation disorder in males or acquired in both sexes. It presents as a missing or low level of clotting factor, and here we have hemophilia A with a deficit in factor 8 and hemophilia B with a deficit in factor 9. The severity of the disease is classified by the level, and we have three forms. We have the severe form with a factor level under 1%, moderate form between 1 and 5%, and the mild form between 5 and 40%. The incidence is between 20 and 25 cases every 100,000 from the male population, one case every 10,000 persons of the total population. From all the cases of hemophilia, 80% are represented by hemophilia A, while 20% by hemophilia B. From all the forms of hemophilia A, unfortunately, 50 to 70% are severe forms, while in hemophilia B, there is an incidence between 30 to 50% of the severe forms. The World Federation of Hemophilia and the Hemophilia European Consortium tell us there are no notable differences in frequency of congenital hemophilia regarding geographic area, race, or social economical level. What I want to mention more is that in acquired hemophilia, cases in the pediatric population, it's quite rare to happen. In Romania, for example, we have only one case reported in our medical history in a pediatric patient, which happened in our comprehensive European diagnosis and treatment center around 5-6 years ago. And also that even though this is a rare blood disease, from the entire rare blood disease population, this is the most common one which we see. To go forward, the clinical manifestation in this disease is by spontaneous bleeds in general without any objective cause. And the prevailing bleeds are musculoskeletal, and here we talk about hemarthrosis, which are around 70 to 80% of the cases. They have a tendency to relapse, and it's really happening. They develop hemophilic arthropathies and joint ankylosis in the end. And the other 10 to 20% of the musculoskeletal bleeds are muscular bleeds. Other major situations between 5 to 10% are central nervous system bleeds, around 5%, and life-threatening bleeds, central nervous system bleeds, which is the main cause of their death normally, gastrointestinal bleeds, neck, severe trauma, and renal. Even though this is a hematological disease, it implies, as we've already seen, musculoskeletal long-term complications, which lead to severe disabilities. The treatment is by substitution factors with coagulation concentrates, factor 8 or factor 9. And in the lack of this substitution, the evolution is widely fatal. When we talk about hemarthrosis, we mentioned the knees, elbows, hips, and ankles, which represent the major joints, and we call them target joints. Afterwards, when we speak about muscular implications, The most common ones are gastrointestinal and intra-abdominal, and here we have the iliopsoas muscle, we have retroperitoneal bleeds and deltoid bleeds. Other major bleeds are the central nervous system, as we mentioned, epistaxis, hematuria, and pneumothorax, which are quite often. And even though with the treatment they don't have 10 major bleeds per year, they still have 1 or 2 major bleeds per year. So we tell to the patients and also for the caregivers that in this disease, their job is to bleed. It doesn't matter if they get the treatment, they will still bleed. Not that often, it's becoming, if they follow our indications, quite rare, but still they will have those major bleeds. One of the most common complication of hemophilia, and also the most severe one, is the presence of inhibitors. When we have these inhibitors, there are severe and expensive complications due to the substitution treatment. And here we talk about difficult hemorrhages administration and a high mortality rate. In the left corner, we have an example of a patient with knee hemarthrosis, which presented to our center, relating that 2 days before he was walking to school around 10-15 minutes. He developed some mild pain after this walk, and during these 2 days he developed this major hemarthrosis, coming to the hospital with the inability to move his leg and with severe pain. And on the right upper corner, we have a small patient around 2 years old, which came for his regular prophylactic treatment. And after the venipuncture, he developed in some hours this muscular hemorrhage. Also, we have an example of repeated hemarthrosis and the damage which they are doing on the patient's joints. And in the end, most of them need arthroplasty. And now we will relate for the imagistic importance for these patients. And I want to exclude some other means of imagistic examination. And I'm gonna mention right now the MRI examination, which is still an option, but not in our case when we want to monitor the joints of these patients. So the joints modifications are not detected by MRI in asymptomatic or almost asymptomatic patients. It's an unjustified examination with a lot of costs, and it doesn't show up the long-term minor modifications, which not all are with a clinical relevance. And here we have the hemophilia early arthropathy detection ultrasound, which is called the HEDAS. And because of these elements, which I already presented, the society developed these targeted protocols. And of course, ultrasound is very fast to do, dynamic, cost efficient, and safe. Is accessible not only in the radiological department, it's a real-time case administration. It has permanent treatment, individualization. It helps us in this process of individualizing. And what we mean by individualizing this kind of a treatment is that by making this ultrasound every day for the patient while he's in the hospital at his bedside, we can modulate the daily treatment. So after beginning the substitution treatment, in 2 or 3 days, the patients may not have symptoms anymore. Many of them are requesting a discharge. And while doing the ultrasound, we see that still in the joints, there is some blood accumulation between 1, 3, 5 millimeters. And the international guides in hemophilia tell us that even a 1 millimeter of accumulation, blood accumulation in the joints, is a major starting point for a huge hemorrhage. So, in many of our cases, the symptoms are silenced because of the treatment which we offer quite fast. But that doesn't mean that the hemarthrosis is already healed. And now, why we are doing this ultrasound? Why it's so important? This method brings adequate correlation between symptoms and sensations, and our patients describe a tickling sensation. In pediatric, it represents a major tool to diagnose due to the correct incapacity lack to properly describe their symptoms, and by this I mean the age of the patient, because we all know that children have their own way of expressing the feelings, the emotions, and symptoms depending on their age. Also, it is a mechanical joint evaluation with maneuvers which can be done in real life. Also, they are insensible to early changes or too late in the joint's pathology. The radiography does not perceive minor joints changes, cartilage, or soft tissue. Also, MRI consumes a lot of time, which is inaccessible for most of the patients and brings a lot of costs. Small children need sedation. Joints modifications are not detected by MRI in asymptomatic or almost asymptomatic patients, how it's in our case. It's an unjustified examinations with a lot of costs, and long-term minor modifications are not all presented with a clinical relevance. But why we enhance this kind of imagistic evaluation? Because it brings a lot of dynamic capacity, so we can put the patient in many positions. So here we have the joint movement, and also we can evaluate the joint during a muscle contraction, which can relate for us can indicate for us some pathologic elements. Also the availability and portability, because we can use the machines next to the patient's bed. And its preferential spatial resolution is in real time in critical situations, made by any clinicians with HEDAS or normal ultrasound certificate. And I mentioned that all this procedure is made by the clinician. But in the end remains the question, who is the most important, the clinician or the radiologist? And the answer is that both specialties have the same level of importance. But because of all these early arthropathy problems with which the patients with hemophilia develop, our targeted specialty would be the pediatrician or hematologist, so in the end, the clinician. Because there are multiple joints to examine, these patients have early changes with a high incidence. They are asymptomatic or almost asymptomatic. We are talking also about time efficiency, multiple examinations, about the target joints which have minor bleeds, severe bleeds, or micro bleeds. And also we take into consideration the radiology department, which has a waiting list. The results may come quite late, and also the need for the clinician to individualize the treatment. And also it would be a bit strange to send to the radiology department the patient with an indication of multiple joints examination without any symptoms. Sometimes my colleague would ask me, how many joints do you want to examine? And I will tell them 6. But does he have any problems in them? No. Any pain? No. Then why do you want to examine 6 joints? And here comes the relevance that the clinician can evaluate from time to time, daily, in case of a hemarthrosis, the patient's joints. And this is how we individualize the treatment. And going forward, I'm presenting also the influence and the importance of MRI, but in our case, why it's not that used. Because first of all, it implies sedation in children, extremely difficult joint positioning due to the advanced osteochondral changes, and we have to think that many of our patients have severe arthropathies with positions of the arms, legs, which they cannot sustain for long because of the pain, high costs and long waiting list. Sometimes we need a contract substance in every joint, which could be impossible and taking too long, and inadequate for regular checkups. Even though it offers detailed information about all the aspects in hemophilia, and we are talking about synovial thickening, cartilage damage, and the early osteochondral anomalies. But as we all know, we could examine only one joint per examination. And after all this, still remains the question if ultrasound technique can evaluate properly the changes in hemophilia. And the answer is yes, because in hemophilia, we have a lot of specific changes in our patients. It's proper for repeated examinations. We can do multiple or complete joints exams simultaneously, and we use it as a permanent monitoring tool. And again, we have the HEDAS protocol or the classical musculoskeletal examination. As an example, we can observe the following. We have pathology activity, so during bleeds, when we can observe some intraarticular fluid, synovial chronic proliferation, also osteochondral modification, and we have chondral anomalies and subchondral bone damages. Also, problems with the synovial. So the vascular response observed in the hemosideremic synovial tissue is not that intense as in rheumatoid arthritis in the acute phase, as having an almost similar aspect with classical arthropathies. So we have also the tools to make the secondary diagnosis and eliminate all the other disease, besides the fact that we already know that the patient suffers from this coagulation pathology. And we have a comparison between rheumatoid arthritis, where we can see that it's an excellent biomarker in the inflammation. It has active and inactive disease, and we can observe the different stages. And also in the active stage, there is a hypervascular signal, while in the hemophilic arthropathy, we use it as an excellent biomarker in acute or chronic hemarthrosis. We observe the hemosiderin deposits, and that leads to synovitis, and it has a hypovascular status. The second most common department where these patients benefit of the ultrasound technique, it's the medical rehabilitation department. And the World Federation of Hemophilia brings in the last years a major element in front of the clinicians as an information, and that it's represented by the fact that the prophylactic treatment and the rehabilitation protocols have the same importance in treating this kind of disease, the coagulation problems. Because, as I presented before, hemophilia is the only blood disease with musculoskeletal problems. And the importance of medical rehabilitation is already recognized worldwide in this case. So the department is using guidance, which also helps afterwards the clinician to individualize even more the treatment. In our department, we have between 40 to 31 hemophilia patients per month, over 300 procedures. Ultrasound is used every maximum 10th session in the rehabilitation clinic, or any time is needed, depending also on the reason why the patient came. It helps individualize the rehabilitation exercises and also to tailor the on-demand treatment. Normally, we check the osteochondral anomalies, the cartilage damage, the synovial thickening, and also we bring forward the new possible problems for these patients. So physical and treatment adjustments are representing zero bleeds and high motor functions for us and also for the patients. The national and international protocols on hemophilia recommend that all these patients need permanent medical rehabilitation and especially joint fortification in order to go forward in life without too many or too early arthropathies. And also, the same World Federation of Hemophilia recommends ultrasound monitoring, evaluation at least once a year, every 6 months, if the patient has severe arthropathies and an active lifestyle, which can imply more faster evaluation and development of complications, and also brings forward again why this technique is very good. And we have technical efficiency with redundant technique, accents on the damaged area extended towards the soft tissue. It's easy to use with conventional ultrasound machines, even with portable devices. It's adequate information regarding the joint status, acute phases, and expected modifications in hemophilia. And it's a monitoring marker for treatment efficiency, joint modifications, evaluation in longitudinal studies. And I mentioned again the HEDAS protocol, which is efficient and dedicated for clinicians, musculoskeletal examination outside the radiology department, time management, so it can be implemented during daily activities. And now we have the question if these new protocols dedicated to hemophilia can replace the classical musculoskeletal examination made by the clinician or the radiology department. And the answer is no, because already a certificate in ultrasound it's needed in order to perform this. The clinician can combine both of the techniques for a more advanced exam, including extra-articular muscular bleeds. And we have a better clinical outcome. We can identify the subclinical pathology, and we can do more frequent measures. This method it's ideal to evaluate the reabsorbing stages of hematomas, and we can modulate permanently the prophylactic and on-demand treatment. It accurately brings forward objective characteristics of the lesions, so this is more individualized therapy. We can adjust the treatment and also confirm the clinical examination. And again, we modulate permanently the prophylactic and on-demand treatment. And it's very important to use it in acute bleeds and also for interventional methods. Ultrasound guidance for suction or injections on site, post-puncture trauma, which is minimized, and exact positioning of the needle while we are doing these procedures. And what are right now the new elements which we have to remember regarding hemophilia and some particulars in this coagulopathy is that early signs of arthropathies are known to be encountered in asymptomatic joints where only one bleeding episode existed or a few isolated. It's identifying the subclinical pathology and influencing the treatment. The radiology department avoids unjustified exams even more for a multiple joints exam, apparently or complete without the symptoms. And HEDAS protocol integrates as a perfect options for clinicians in the hemophilia centers with the clinical exam. Ultrasound remains a practical procedure, fast and easy, especially cheap, necessary in the early diagnosis of arthropathies, acute hemarthrosis, evolution, and individualized therapy on objective data. Even with an early prophylactic regimen, arthropathies still develop. Arthropathies are characterized by synovial hypertrophy, bone and cartilage damage from repeated bleedings, major morbidity cause in patients with hemophilia. Prophylactic treatment represents the standard of care in severe phenotype forms. And here also we develop a comprehensive team made of the pediatrician or hematologist, radiology department, orthopedist, surgery, physical rehabilitation doctor, and his team. So in order to go forward with a complete plan, we have to work as a team also. And the objectives still remain life prolongation, disability minimization, social and physical comfort, ensuring the entire development and potential of any patient. In the end, I appreciate the invitation for this conference. I appreciate spending your time for listening this information and my paper out. Thank you.